I want to talk for a few minutes about urgent care. What do I mean by urgent or unscheduled care? Well, it's the hundreds of millions of interactions that we all have from time to time, with everything ranging really from pharmacy to going to see your GP for an urgent appointment, to visiting an out-of-hours clinic, perhaps a walk-in centre or an urgent care centre, and even calling 999 or going into accident and an emergency. I've been working in this area with the NHS for about a year, and I see there being several connected problems and issues. What I'd like to call a mismatch between supply and demand. What we want to access in terms of A&E as patients and citizens isn't quite what's being provided. We overuse 999, we underuse 111. We go to accidents and emergency for relatively minor issues or conditions that don't fulfil the purpose that A&E is intended for, of being there for life-threatening accidents and emergencies. This is a problem that's not new, actually. For many years, there's been this mismatch between supply and demand, the customer, if you like, not quite doing what the system expects them to do in terms of the way it's configured. But it's become a growing problem. Why? I think for two or three main reasons. Firstly, the era of significant NHS percentage level increases in its budget are largely gone, whilst the funding for the NHS will continue to be at high levels and in real terms will not be cut in the future. The rate of growth for the NHS in terms of money is slowing down. As a result, these kinds of mismatches between supply and demand, which inevitably cost money, get brought into sharper relief. The second and connected issue is that as a country and as a National Health Service, we are trying in various ways to shift activity from secondary care and into primary and community settings. Why? Because it's cheaper often to support the kinds of chronic conditions that we have as a society at home and in the community, and much more expensive to treat these on an unscheduled basis in hospital. So for these reasons, it's very important that we bring back this balance between supply and demand within the urgent care system. What's being done about it? Well, Sir Bruce Keogh is in the process of looking at the urgent care system, and he's published a phase 1 report, an update report, and probably after the election he'll also report again. And his proposals make an awful lot of sense. He wants the urgent care system to be better connected. He wants, like us actually, for accident and emergency to be used by people who need that very high-end, expensive service. And he wants a greater and more prominent role for lower cost advisory support in pharmacy and critically in the non-emergency urgent number 111 that has faltered in its start and is probably not at the salience in the public imagination that we would want it to be. But I think there's a piece missing from the Keogh work, which is that we may fall into, if we're not careful, an old trap of building a system which people don't want to use because their personal motivation, their psychology, drags them towards some of these more expensive parts and features of the system, such as walking into accident emergency. Some of the work that we've done with health economies shows that we do have an issue in relation to the brand of A&E in the public imagination. Half the patients that we surveyed in 2 A&Es were regular attenders of those A&Es, using A&E, if you like, for their primary care needs, the first point of contact for relatively minor issues or issues connected or conditions connected with their long-term conditions. We also found that most A&E attenders are young, under 40, using A&E perhaps because they don't have the experience or the connection with primary care that perhaps some older people in our society do. And the stats tell us that more people choose to walk into A&E than call the advice line 111, which for us has to be wrong. So we're back to this notion of a mismatch between supply and demand, increased in salience by the need to manage costs within the NHS and the growing general demand for healthcare services that we're facing as a society. Now, what can we do about it? Well, the first thing in our experience is that we have to start locally. Each health economy in England is configured differently, different patterns of hospitals, acute hospitals, other providers, different patterns and quality of primary care services, different geographies, rural, urban, and the connectivity between the different parts of the NHS in each locality will change. What we need to start with, which in my view, working in this area over the past year, we're not getting right, is a refined understanding of who is using in a locality parts of the urgent care system. That refined understanding means knowing who's using what, but more than that, what age they are, what their socio-economic circumstances are, what their proximity to various points of the compass is in terms of the healthcare system, what GP they're registered with. So getting to a refined understanding of who the patient is in terms of the different parts of the urgent care system they're accessing. That allows us to segment the population in terms of high use, high risk, low use, low risk, in terms of those demographic characteristics. The second and critical question to ask is where we identify high use of urgent care segments within the population. They may be frequent attenders, they may be young people, they may be people who are not registered with a GP, that we're asking the question of those patients why they're using the system in the way they are. And that's a profoundly important question to be asking if we want to do anything to influence the demand for healthcare services and want to construct anything like a sensible strategy for intervening on the demand side. Once those two questions have been answered, the strategic foundations locally are laid, and it's possible then to, using the Bruce Keogh work, but also using behavioural science and behavioural economics, to make the changes that are needed on both the supply side, the configuration of NHS services, and on the demand side, who the patients are using the system and why they're using it, that are needed. Without that basic understanding, we're searching in the dark and making guesses and hunches about what our urgent care systems locally should look like. So, in summary, we've a mismatch between supply and demand in healthcare, in terms of urgent care. That's brought now into sharp relief because of cost pressures and because of more general demand issues in terms of healthcare services. If we really want to avoid the trap of building a new urgent care system which the patient doesn't recognise and doesn't want to use, we have to understand the demand side better. And that's what I'm doing, and I hope many health economists will start to do up and down the country going forward.